Good afternoon. Thank you very much for the opportunity to be here today. And thank you very much for your kind and gracious extension of technology to help make this presentation. I'm Laura Housman, founder of Access Solutions Consulting. I'm here today representing Kashi Clinical Laboratories. In the audience, we have Ms. Dina Balbach, who is the Chief Operating Officer for Kashi Clinical Laboratory. And on the telephone is Dr. Philip Halloran, who is the developer of the molecular microscope diagnostic system, is a nephrologist researcher, and as professor, Department of Medicine, Division of Nephrology at the University of Alberta. Thank you so much to Palmetto MolDX, to Drs. Gerard and Bien Wilner for their support and engagement throughout this process. We very much value and appreciated the engagement and believe that the two LCDs for MMDX represent that strong leadership and guidance. For proposed LCD 38258, molecular microscope diagnostic system for the heart, one proposed suggestion to the coverage criteria language, which I've underlined here, where demonstration of non-inferiority would need to incorporate studies of similar design and enroll a similar patient population to MMDX heart, so that there could be a strong comparability with those inferiority studies. The rationale is the clinical validity of MMDX with respect to histology, function, HLA antibody status, and outcomes was established over 35 years via 34 publications and international prospective trials, notably InterHeart, which is registered at clinicaltrials.gov. The clinical performance of MMDX, as evaluated in InterHeart, is a prospective clinical study doing an analysis of over 1,200 new indication heart biopsies from 482 unique patients in 8 international heart transplant programs with 15 investigators from 6 countries. And these are consented patients in these prospective studies showing a full range of heart biopsy from day 1 through greater than 30 years. So any demonstration of non-inferiority is asked to be considered in the context of this construct. That is the conclusion of the comment for heart. Dr. Gerard, would you like me to move on to kidney?
Certainly, unless, does anyone have any questions? Let's go to kidney.
Let's go to kidney, thank you. Proposed LCD 38260 tests on allograft kidney biopsy tissue to assess for graft rejection. Again, solid coverage criteria language for sure. The underline is suggested and proposed. Established through genome-wide annotation of the biologic processes in organ transplantation, creating an integrated picture of the biopsy-specific molecular phenotype. The rationale there is the, again, extensive development of unique tissue-based genome-wide annotation built via classifiers using machine learning algorithms across a very large probe set representing over 20,000 genes that predict not only the archetype scores above a cutoff, but also create an integrated picture of the molecular phenotype that is specific per biopsy. This work led to disease reclassification processes across notable bodies and organizations, such as the Banff classification, and for the first time introduced unsupervised approaches as well as supervised approaches to classification, and also the ensemble approach via machine learning to create accuracy and stability. And for all those reasons is the proposed addition to that language. Lastly, for kidney, LCD, there are 2 current coverage criteria ICD-10 codes, and there is a proposal to add one more, T86.19, other complications of kidney transplant, to be similar to other complications of heart transplant as appears in the heart LCD. Thank you for your consideration.